Okay, so patient has pelvic pain.
Ooh. Coming from right there from the uterus, right? And it's very heterogeneous. Do you have the
Here.
sagittals? Yeah, like there. I see it coming. Is that the uterus? Can you show me the sagittal or?
Is it lyomas arc? Looks very heterogeneous, but again, I don't know. MR.
I mean, MR exactly. So,
Okay, so basically
so
it was called fibroids. MR was not done.
wait. So where's the uterus at? Sorry, coronal, maybe coronal.
This is
Sorry.
this is the uterus.
No, I know. I want to see its relationship to the. Okay. Oh, I see. So the entire uterus is replaced by this heterogeneous ugly mass. But there's something on the adnexa too. Uh, do you have the coronal?
Oops. Oh wait, hold on, sorry.
Oh yeah, it's ugly. Look at that. Like that area looks not typical of like a nice homogeneous fibroid. But
Yeah.
MR, I would still recommend an MR.
Okay.
And
So
then
that,
and then are there, oh, those are just maybe parasitic vessels along the left lateral margin right there.
yeah,
Or is that the ovary?
I think those are gonadal
Oh,
vessel,
gonadal vessels supplying the mass. Okay.
or like the ovary might be squished next to the mass, whatever it is.
Yeah,
Okay.
I was having a hard time figuring
Okay.
out
So
what's going
anyway,
on
that
there.
was the original. It was like at some outside hospital. So it was uploaded later. And then a year later, it looked like this. So much larger and more extensive.
Not good.
Okay. So would you biopsy this? Like we were now concerned this is a leiomyosarcoma. So would you biopsy this? Oh, and that
I
might even be an IUD or something. I don't know what that is over there, but oh no, just some calcs.
I mean, the question is, would MRI change anything? Like, I mean, it needs to come out because it's growing rapidly.
Mhm.
In my mind, like, okay, is it's not, to me, it's not a question of biopsy. I feel like would MRI change the surgical management? This is like a surgical case to me.
Mhm.
Is there lymph nodes? Like, is that thing right there, like interior cable part of the mass, or that? Oh, maybe that's just part of the mass rather than a lymph
Part of the
node.
mass.
Okay.
We did want to biopsy it.
And it's
So
very lobulated looking, like, but maybe that's just one big mass that's now has this weird multilobulated thing rather than like a peritoneal implant or I don't know, it's hard to tell.
okay. Anyway, they wanted to biopsy it. So, and we were like, it's grown so rapidly in a year. We don't think MRI is going to make that much of a difference. So they biopsied right here. Okay. And it came back leiomyoma.
Oh, wow.
I don't think that's I don't I still wouldn't.
Was it like representative of the mass? Like, I don't know.
Okay. So hold on.
Sorry.
Sampling error.
Let me get an
I
That's right.
MRI
Okay,
and
good.
check this out. Check this out. So look here where we
That
biopsy
looks, yep, normal fibroid.
looks like a
And
fibroid.
yep, left side is
Here,
abnormal. There it is.
exactly.
Yep.
So this was actually like a crazy, we're like, oh my gosh, like there are simultaneously fibroids and this
Yep.
sarcoma.
Sarcoma, yeah.
Yeah, so this is the spare, not great. We've got a lot of dielectric effect going on here, but I will show you the diffusion because I know Nelly is a LMS diffusion expert.
No, I'm not anything. I'm learning and I get, if anything, just I want some clarity.
So anyway, there was a lot of restricted diffusion in that side of the mass, like on this side. And it was less than 900. It was 600
Oh, wow.
ADC. So we still said, okay, we think it's a leiomyosarcoma and we think you
Yeah,
actually, ironically, biopsied like the fibroid half of the mass, which I think on CT you could not tell the difference between the two. So I thought this was
absolutely
like actually a
agree.
really nice example on MRI of like fibroid versus malignant T2 gray tumor.
Yep.
So then they biopsied this part and they ended up resecting this whole thing. And interestingly, it was not a leiomyosarcoma.
Stump.
Dun, dun, dun. It was
Or
not a stump,
yeah.
but good guess. It was a malignant PEComa.
Oh, wow.
What?
Yep.
Oh my God.
So I'm just going to bring up.
Forget it. There's no. Oh, like what?
So have you guys heard of PEComas? You've heard of them.
Yeah.
Yeah.
I was like,
Every time I hear about a PEComa, I'm like, what is this again? So anyway, these are mesenchymal tumors. So they include AML, clear cell sugar tumor of the lung, LAM. And because of all of this, they can be related to tuberous sclerosis. So if you get a PEComa, it's rare in the GYN organs, but of the GYN organs, the uterus is one of the more common ones. And see, uterus considered one of the most common sites in the pelvis. But in general, uterine PEComas are very, very rare. So, you know, if they have TS, maybe you can bring it up. I still think we just have to say this is malignant and still would have favored a leiomyosarcoma, but this happened to be a malignant PEComa. And there are no, it says, unfortunately, due to the non-specific imaging appearances and scarcity of reported cases, there are no specific imaging features recognized.
surgical. So your case is interesting because there is added value of MR, right? Because it tells you where to biopsy.
Yeah. And it was like basically, I mean, they could have easily just gone like one, you know, few centimeters over and gotten into the mass, but yes, it was like very, very helpful. So actually, after the first biopsy came back as leiomyoma, they're like, do you think these could just be fibroids? And we're like, no, we still, like you said, like we have to say, is this concordant or discordant with what we think?
Yeah.
It was discordant, go back. So we guided them to this area. And then they said it was a probable PEComa because of the staining. And then when they went to resect it, it all came back malignant PEComa. So PEComas aren't necessarily malignant. They can be low grade of uncertain malignant potential and then malignant. And then this one actually was like, there was PEComa even growing along the serosal border. They resected a bunch of colon and there was PEComa like growing along the colon and everything. So it was just
Fantastic case. Yeah.
crazy case. So yeah, it was growing along like these bowel loops and stuff. But there was no positive lymph nodes and no peritoneal disease per se. So okay.
I'm going to share. Okay. This is the CT, a remote CT.
Something in like the iliopsoas, like hyper.
Yeah. Yeah. Exactly. There's like this
Sorry, I missed
kind of,
this.
what?
I just came back. I was like gone for a bit.
Oh, we just
Sorry.
started. So I'm showing this CT and Aarti said it was something in the iliacus that we see here. Yes, there it is, asymmetric enhancement.
And enlargement, yeah.
And here
It's
is
so
the
it's so like non-mass like though. It's whoa.
this was done later. There was growth picked up later. Like this was a very, very old study, but we got an MR for
And
further
it's not arising from the bone,
characterization.
it's like arising from the muscle.
That's correct. That's
Some
correct.
kind of sarcoma.
This is an intramuscular lesion. So that's the STIR. Here's the T2, which shows the same thing. Here are the dynamics. Here, oh, here it is. Here. And here's some coronals. And this went on to biopsy, and this was a hemangioma, intramuscular hemangioma.
What?
Yeah.
It grew so much.
It did over a course of 5 years.
Okay. Wow.
And here's some notes from Copilot about intramuscular hemangiomas. So they're benign, and there's different types. There's 3 different types. They occur in young adults and adolescents, and most are thought to be congenital. MR imaging, so for cavernous, I think imaging can be very helpful, specifically MR. You can have cavernous hemangioma, so large vessel type, And I saw some big vessels here, but I also saw some small vessels. And then you can have a capillary hemangioma, small vessel, and then there's a mixed type, which is a mix of these two. And then on MR, like we saw, very hyperintense on T2 with variable enhancement pattern depending on the type. And they are considered a vascular anomaly, distinct from vascular malformation and AVMs. They're benign, but they can be symptomatic. Patients can have pain. They can have slow growing painless mass. It could be asymptomatic and sometimes can lead to functional impairment. So I think if they're symptomatic or interfering with quality of life, they can get surgical resection, but recurrence occur in up to 20% of the cases.
I've had a couple of cases of these that are, like we presume they're sarcomas and then they come back as like large hemangiomas. One clue on CT is that they can have phleboliths in them. So I found that to be helpful at times. But did the enhancement pattern, there was no nodular kind of enhancement, right? It's not like similar to like a liver hemange in any way.
Yeah, that's a good question. Let me just show you the dynamics again. So here, I'm pulling up the pre-arterial, and then we have the delayed is here. I think there's progressive enhancement. What do
Yeah,
you think?
it's just not the like peripheral nodular, but it's so much more dense of a lesion, it seems. But yeah, I can see. Do you think it's so funny. If I got this, I would have consulted my MSK colleagues. And I wonder if they would have been like, oh yeah, this is like a classic intramuscular hemange. Yes. You know what I mean? Because they might see a lot more of them.
Yeah, that's a good question. And I think the patient got biopsy first before the MR.
Got it. I do know if you're biopsying possible hemanges, like especially for example.
Oh, I'm sorry, I made a mistake. This was there was an interpretation of outside imaging, and they called it a low flow vascular lesion hemangioma.
Wow, cool.
Yes, so that was called ahead of biopsy.
Cool. I do know in the liver, if you're trying to biopsy a possible hemangioma, you need like large cores, like not just FNAs, because if you do FNAs, you're just going to get like blood. But they want to see like the large kind of like engorged blood vessels, the walls of the blood vessels on core biopsy to say hemangioma.
Maybe same for MSK.
Yes. Ring, ring, call MSK.
So this patient has a history of cervical cancer. She was irradiated and then developed strictures in the both distal ureters. And I'm not showing with that imaging of cervical cancer or strictures of ureter. She had bilateral PCNs. And after that, she got a procedure done. So let's see how the kidneys look like on this urogram. Kidneys and ureters in particular. So this is the ureter here. So what's happening? Ureters are
Connected to an ileal conduit
Mhm.
or some kind of, is it going to the bladder?
Yeah, so ureters are anastomosed to this portion of ileum, and that is going and attaching, as in that has been anastomosed to the bladder.
Is that called a chimney?
They call it reverse 7, but I was looking at the internet.
reverse
So
7.
basically, reverse 7 is not exactly like this. Reverse 7 is when they connect similarly a loop of small bowel here, and this small loop, this loop of small bowel is connected to a neobladder. This was not a neobladder, so in essence, technically, it's still not reverse 7, but yeah, it is still something like reverse 7. And the reason it's called reverse 7 because if it is made high up, it can look like a reverse 7 shape. And let me just show that to you. Hi, the system is giving me some issue.
Can you
So this
scroll
is,
up a little? Oh yeah, it does look like a reverse 7. Oh, that's cool. Wait, so it's connecting both.
yeah, if it is slightly higher up and it
Mm.
joins a new bladder, then it looks more like reverse 7, and it is the actual reverse 7. In the case that I showed, it's with the native bladder, although the native bladder is small in caliber because after radiation, and the anastomosis with the small bowel is not that higher. So probably it is the same mechanism, like same functioning, but it's not forming that classic reverse 7 shape. But it is in a sense similar to that only.
When do we don't see this very often.
Yeah. So basically what happens is if there is ureteral stricture, most of the times what we end up doing is psoas hitch. So because of radiation, the bladder had fibrosed and the bladder capacity was reduced. So the bladder could not be lifted high up to perform a psoas hitch in this patient. So that's why they did this. They interposed a small loop of bowel.
Yeah, no, I know. Right.
It's not a common procedure.
Cool.
This is a patient who had a non-con elsewhere, was referred to us later for this pelvic finding. So
Seminal,
the patient,
Or female?
seminal vesicle
it's a
lesion.
man.
Mm.
Seminal vesicle lesion.
It's a man. Yeah. Seminal vesicle lesion. Okay.
Yeah.
Great thought.
It's very blobby. Wait, and is it connected to the ureter?
It's hard. The ureter is not dilated, but you mentioned a great point, which is there's a congenital absence of the left kidney.
Oh, so it's ureter opening on the seminal vesicle, and that's why it's big.
Ureteral opening on the left seminal vesicle, and that's why it's
No, but
big.
then we do not have left kidney.
Correct.
And actually, you have a nice pancake flat adrenal gland there on the
Pancake
left
adrenal
side.
gland.
Your mouse is kind of over the middle of the.
Oh, sorry.
If you go down through the left adrenal gland, it's flat,
Right there.
not split. Yeah, so that's like a suggestion that congenitally absent left kidney.
Well, that's good to know.
Yeah,
Okay.
because the kidney rises out of the pelvis and splits the adrenal gland. So when it's congenitally
Yeah.
absent, it's called a pancake or flat adrenal.
Oh, okay. That's great.
Yeah.
Okay.
Go down
And
back
so
to-
what?
Yeah, go back to the seminal vesicle area.
Okay.
Is it just like a massive seminal vesicle cyst with the absent kidney, like Zinner syndrome?
That's a great thought. So at the when we were reinterpreted or when we were consulted, when the patient came for a second opinion, the after that CT, the patient went on to get a PET CT, and there's no FDG uptake, and so we had I think either we had recommended or they subsequently got it. Oh, we recommended an MR, and this is what the MR showed.
Oh, just dilated
Yeah,
tubules.
super dilated.
Yeah, and then let me give you the T1, which is diagnostic or contributing to this presumptive diagnosis that Aarti already shared.
Hmm.
Of Zinner syndrome.
Yes, yes. So it's just a really dilated ectatic seminal vesicle, and we see that in patients with congenital absence of the left, or just kidney, a kidney, and that's what this was.
Wait, what is the stuff going upwards? Like those are the gonadal vessels also?
Let me trace it. Let me see if I can trace it because it's catching my
Or is
eyes
that a
too.
ureter? I think that's like a remnant ureter.
It doesn't look like a ureter. It looks, if it is, it's tortuous. Let me see if it doesn't go up very high. Here's the
Something
larger
like
field.
abortive duplication, abortive ureter. Not duplication, but aborted ureter.
Left retroperitoneal extension. So my God. Oh, maybe.
Or somehow they're saying the seminal vesicle is like extending up into the retroperitoneum.
Well, because you have the vas, right? It goes up and then to the left spermatocord. So could that just be a continuation as it exits?
Wow, that's cool. I haven't seen that.
Let me see if I can. Let's see. Here's the. Can we trace the vas into the inguinal canal? It should be, yeah, coming at least around this course and then left lateral and then anteriorly. It's hard. It's
I mean, I
hard.
guess it probably is just like some congenital migrational thing where the seminal vesicle grew up the retroperitoneum.
Yeah.
Very cool.
Can you go to the T2? There was a finding
Oh,
in
yes.
T2,
Yes.
not in the seminal vesicle, but otherwise.
Okay, this is a fat sat T2. Do you
No,
want
the
the regular?
regular non-fat cell.
Okay.
All the way down,
All the way down.
Are you
the
gonna say
penile
the
shaft.
utricle?
Penile. Okay.
Yeah, there. Slightly up.
Up.
The other way, please. Still up.
Okay.
Yeah,
Oh,
stop.
there's
Yeah.
something there.
So you see blood fluid level, and that's normal for penile shaft.
Oh.
Yeah, you will see that very often.
Oh, let me look
Because
at
of the
the
blood just like
T1.
layering when it's in the cavernosa.
It's T1 ISO. I guess that makes sense because it's flowing blood
Yeah,
and not clotted blood.
yeah. It can be
Oh,
urinated
wow.
simply
I never really
bilaterally.
noticed. But that makes so much sense. Thanks for bringing that up.
Is there also a utricle in the prostate?
I think there was. Yes, there it is.
Yeah. Cute.
Yeah.
Okay.
Oops. So how do we remember Zinner syndrome? So similar to OSVIRA syndrome, which had a very complex name to begin with, but OSVIRA stood for obstructed hemivagina ipsilateral renal agenesis. Zinner syndrome can be summed up as OSVIRA, which is obstructed seminal vesicle and ipsilateral renal agenesis. Sorry, am I audible?
I'm just not sure if that helps me.
Yes, you're audible. And I'm trying to digest what you just said.
So how we have OSVIRA syndrome, and it's called mesonephric anomaly. So OSVIRA had this big name, Hurlin-Wunderlich-Werner syndrome, and then they were like, we are done with eponyms and let's give it some name which is close to what it contains. So OSVIRA stands for obstructed hemivagina ipsilateral renal agenesis. So similar to that, because Zinner syndrome is also a mesonephric anomaly, so it can be summed up as OSVIRA, which stands for obstructed seminal vesicle and ipsilateral renal agenesis. Yeah. Because that's what it is. There is ejaculatory obstruction. So seminal vesicle is essentially obstructed and ipsilateral kidney is absent.
Nice. I like how it's more descriptive. I'm just gonna have to try to remember this. OSVIRA.
And can I brag something?
Sure. Oh, this is your paper?
Mm-hmm.
That's the best way to learn.
That's right. Write about it.
Nice. In the Polish Journal of Radiology.
Mm-hmm.
Your reach is wide.
Thank you. Something anterior to the rectum, submucosal rectal lesion.
Good. So yes, this is a female patient. There's the bladder, there's the vagina, urethra, and then there's this lesion, like Yashant said, submucosal along the anterior rectum. So what do you think it could be?
Do you have the post-cons
Yes.
or subtractions?
Here's one post-con. And actually here is,
So is it enhancing internally? Is that real?
yeah. It was enhancing, not super avidly enhancing, but
Yeah,
subtly
centrally.
kind of enhancing, like almost like a stalk kind of thing, but
It has a really interesting T2 signal appearance. Like it
yeah,
doesn't have the evil grade like I wanted to see.
it actually does. Hold on.
Does it? Okay. Oh, it does right there. Yeah, yes. So just I mean it's coming from the rectal wall. We've seen neuroendocrine tumors. They are more enhancing and more uniformly enhancing. So I don't know if this is just a weirdo neuroendocrine tumor or not.
Great.
And there's extension into the upper anterior anal complex. Is that there's T2? So it could, I mean, it would be weird, but like an anal cancer that's kind of, but it looks more epicentered in the lower rectum.
Yeah.
Rather than the upper anus.
Yeah, exactly. So this was
maybe invading. Yeah, go ahead.
Yeah, this was a gist. So this is rectal gist. So just remember, gist can be anywhere along the GI tract, coming from the submucosal pacemaker cells. And actually for rectal gist, MRI is much, much better because we can see the planes well. We can, gists are usually pushers, not invaders, but you can see the relationship with the vagina, and it can help with like pre-surgical planning, and then the relationship with the sphincter. In this case, it was involving the sphincter, but they were able to kind of do a super low resection and like preserve it because they don't need to get as large of a margin on a gist. They did do Gleevec and shrunk it down and then resected it. So yeah, this was a gist. And then I have a companion. Okay, here's kind of a companion case. Also a pelvic mass in a female. The bladder was pushed anteriorly, and we thought that the uterus was actually over here, kind of pushed by the mass, not, oh, hold on one second, sorry. We thought the uterus was here. There's some air in it because there's been a recent procedure, but this was the mass. So basically kind of retrouterine, associated with the sigmoid colon and rectum. So again, thought like possibly a gist. I'll tell you, this one was not a gist. Usually when gists are this big, they get more centrally necrotic. So this was more of a little bit more of a bland looking thing.
Sorry, can you go down to the lower pelvis? I want to see if it's herniating through anything.
No, but that's a great idea. What were you thinking of?
Oh, angiomyxoma.
Yep. Yep. And somebody actually in our case conference brought our local one here brought that up. So those usually, they have this nice long spindly appearance, but they usually herniate down into the ischioanal fossa.
And then we could see it communicating with the rectum. Is that right? Like at 10 o'clock position, maybe low rectum, or can we see it like right there? Maybe it's hard on CT. I probably would want an MR.
Definitely pushing, or initially thought maybe arising from, or pushing, or if arising from, this would be the only major thing like there. Anyway, this was a solitary fibrous tumor.
Do we do MR, or do we just go straight to biopsy, or how did we diagnose it?
It was a while ago. Oh, there was an MR. Let me see if there was an MR pre-op.
I don't know that I would ever consider that, but we've seen cases like that before, haven't we?
Okay, there's an MR. Here it is.
Ugly gray.
It almost looks like our PEComa. I'll show you some more MR images. Here's the enhancement. I don't know if it's very specific,
But it's easier to see the separation between the rectum, or like mass effect on the rectum on the MR than CT.
Yes. So anyway, that was a solitary fibrous tumor, and then it was resected, and now there are liver metastases. So solitary fibrous tumors are generally low-grade malignancies. Most of them do not metastasize, but they can metastasize even up to like 10 to 20 years later. So you need kind of lifelong surveillance. Larger and more aggressive ones tend to metastasize. So yeah, this is one of the more rare ones that can metastasize. These can be, classically in the pleura, but they can also be anywhere in the body. Retroperitoneum. I've seen some along the falciform ligament, so along like fascial surfaces, in the pelvis, presacral area. I've even seen some in like the subcutaneous tissues. So yeah, solitary fibrous tumor. Okay.
This was a CT that was done a couple years prior to the MR. Patient.
They seem to have like deviated, medially deviated
Mhm.
ass kissing ovaries.
Yeah. So patient has endometriosis. And patient a couple years later got an MR, just for preoperative, I think it's preoperative, evaluation prior to endometriosis surgery. Came as a consult,
Are you
and
showing massive ovarian edema?
Yeah, it looks super.
yeah.
Yeah.
What do you think?
Is it torsed?
Yeah. So here's let me show you the post-contrast sequences. And the patient was, believe it or not, asymptomatic. Let me see. Here are well, not quite asymptomatic. Patient had kind of just low-level symptoms. That's been ongoing for a while, but here is the pre right there. It's ISO, and then the post is here. Our GYN protocol, we do these obliques. So here's a subtraction, and there's kind of absent enhancement. The follicles are a little bit enhancing, but generally the ovarian stroma is not enhancing, and this was ovarian torsion on MR.
Yeah. Wait, did you show the black ring like follicular sign?
Oh, is that what this is called?
No, like on the T2, if there's like a hemosiderin ring, isn't that what it's
Oh, let me
like you
pull
guys
up
are
the T2.
is concerning for like, oh, we don't know, it's not really prominent here.
What's the black ring?
If you have like a hemosiderin ring around the follicles, that's even more concerning for like complete necrosis of the ovary.
Got it. The other thing that I think I find helpful on T2, if you start to see hyperintensity, you start to have hemorrhagic torsion.
On T1, you mean?
I mean, T1, excuse me, yes.
Yeah,
Cool.
one thing I find challenging is how do we differentiate ovarian torsion versus massive ovarian edema? Pretty much look the same etiology. I don't know, what's your experience?
Crickets. I thought massive ovarian edema was was like a sign suggesting torsion.
I think they are different.
Okay, so it says massive ovarian edema is a rare enlarged edematous ovary. It is not, like I was just suggesting, part of torsion. Oh, it's recurrent partial torsion of the mesoovarium with obstruction to the venous and lymphatic drainage are the most probable cause. So I guess to answer your question, Yashant, I'm not sure, but it seems like it's in the spectrum of, related to at least partial torsion.
Mhm.
Yeah. 15% of cases have an underlying cyst or mass. Sounds very similar to torsion. So yeah.
So this tiny submucosal mass, supremely dark on T2.
Leiomyoma.
That's what even I thought, but
Do you
it
have the
actually came.
post-contrast?
Or was there an injection?
Mm,
It's really dark. Is it dark on all sequences?
Yeah. It's tiny, so we are not seeing it as well. This thing.
I haven't seen GIS or neuroendocrines be that dark, but I guess those are the other two common submucosal rectal masses.
Yeah, that's what even we thought, but I have the path. It says GIST 1.2 centimeter low grade spindle cell type.
Maybe the spindle cell is making it dark.
Yeah. It's positive for CD117, DOG1, patchy.
Nice. Did they resect it or just biopsy it?
They biopsied it.
Okay. It seems like small enough that you could just watch it.
Hmm. No, and then they did transinal excision after biopsy.
Oh, nice. As soon as I said that, I was like, but maybe like I know for small gastric GIS, which is the best location, they can just watch them, but I'm not sure about rectal, which has a worse prognosis. So nice.
Hmm.
Okay. Slowly scroll down.
Ooh,
Pancreatic cancer, peripancreatic.
oh,
Okay.
there's a lot going on.
Yes. So, okay. So first of all, we noticed that there's biliary dilation, and then there's all this lobulated stuff in the portal hilum area.
There's vascular invasion
Vascular invasion.
Is this choledochal
right
cyst
there,
also,
there,
Lynch?
or maybe it's just displacing.
Either that or pushing on the portal vein, but
Yeah.
with that. Okay, then somebody said pancreas. So pancreas is here, it's squished, it's displaced, there's some ductal dilation. The pancreatic head is over here. So it was not a pancreatic mass.
Is it choledochal cyst with some mass? What is that?
It's not a choledochal cyst.
Where is gallbladder?
Good thought. It's basically here.
Yeah.
So gallbladder cancer with periportal and retroperitoneal nodes.
Yes, yes. So great, great. Because sometimes when the gallbladder is like disappearing, we forget how bad gallbladder cancer can be. But this was a primary gallbladder cancer. We basically suspect, and then large necrotic confluent nodes. And these nodes can often be fibrotic and cause biliary obstruction. So even though it looks like the mass over here is like even bigger, these are all just like nodal mets. And then this we thought was like a big biloma, kind of from like ruptured gallbladder / bile ducts.
Shows the liver mets, right lateral
Right lateral.
there.
Oh yeah. Liver mets, yep. So yeah, unresectable.
Yeah.
Yep.
Can I see the coronal?
Oh yeah, and then large retroperitoneal nodes as well. So those are metastatic nodes. The hilar nodes are like not truly distant mets, but very bad prognosis. Like say you just had a gallbladder cancer with one node, they would consider that like a really bad prognosis. The intrahepatic mets are considered mets, and then the RP are considered like distal mets as well. So we've got like all of these necrotic nodes, the big biloma, and then the gallbladder is like the primary gallbladder cancer with some stones.
Wow.
Yeah, and then there's your biliary obstruction from the nodes. Yep.
So that's the peripheral follicular rim sign in ovarian torsion. Basically, it means that the follicles which have migrated towards the periphery, they have T2 dark rim that can show T1 hyperintensity, and it is suggestive of perifollicular hemorrhage. It is slightly advanced stage in ovarian torsion, and definitely, which means slightly worse prognosis.
Yeah, so the one that you showed, Nelly, like,
Hmm.
I'm wondering if it was sort of like the massive ovarian edema in partial recurrent torsion. Because, if you think about it, endometriosis, like there's a lot of fibrosis. So I was wondering like
Mhm.
if that would make the ovary less likely to fully torse.
Or it can lead to chronic torsion. We've seen cases.
Oh,
of-
because of the adhesions and stuff.
Yeah, and they get. I showed one before of hemorrhagic ovary torsion. It was
Yeah.
You had shown months ago.
It was in radiology, actually. That's a case study. Can you pause? Just kidding. Okay, so here's the case of that I had presented previously. So it's the ovary is huge, T1 hyperintense, non-enhancing, and here I remember Victoria saying something about like it has a cerebral look to it, and then that's a T2, and then this is the laparoscopic images. It was chronic adhesions from endometriosis that led to this chronic ovarian torsion with massive ovarian enlargement.
Nice.
Was
This is your case.
This was a case. This was a case, yes.
Very cool.
So endometriosis can lead to it, to torsion. Ooh, the ureter. Ooh, oh my goodness. Well, initially I thought it was like XGP, but then I started seeing all these soft tissue lesions in the proximal and the distal ureter.
Okay, so yeah,
There,
it
thickening
looks like
there.
stones, but there's also all these low density lesions. So a lot of the kidney look like XGP, right?
Yeah.
Okay. And then
But then distally, there's also
there's like
abnormal. Yep.
weird soft tissue, but the ureter's still going through it.
And there's like this.
More soft tissue mass
Yeah.
and a stone.
So I don't know if it's just an exaggerated reactive response or if there's like superimposed malignancy just from chronic inflammation.
Okay, so that's everything we thought. So they did multiple biopsies of the ureter. They even did a percutaneous biopsy of here, and everything came back chronic granulomatous chronic inflammatory tissue.
Do we test for TB?
I don't know, but basically they called it XGP of the kidney and of the ureter. So I had never seen it of the ureter, but if you think about it, this is almost like a staghorn situation, right?
Yeah.
And XGP can cause this like infiltrative inflammatory soft tissue that can even expand like beyond the kidney. It can cross fascial planes. So here it was doing it around the ureter.
And I mean, if this is usually resected, and they would have to do like a vascular reconstruction because the iliacs are also occluded.
Yeah, they decided to just leave it be. I have the MR of it as well, but for now they're just
probably look scary.
Yeah. Yeah. I'll just show you. Let's see if I can. This was the biopsy of it. Percutaneous. Nice.
Nice targeting. Around that colon. Look at that.
Yep.
Wow.
Bold.
Yeah.
So we have this lesion. Any thoughts?
Well, where is it coming from? Is it retroperitoneum or is it?
Yeah.
It looks
retrograde.
retroperitoneal to me, like it's like splaying the IVC and
Yeah, like a paraganglioma. I'd
Or-
stick lymphoma in there still too.
or IVC leiomyosarcoma because it has like that broad
Oh
interest.
yeah, and there's like a little teardrop sign with the IVC.
This looks very similar to that case I showed before.
Yeah, that's a
But
good
mine
one.
turned out to be like a neuroendocrine actually.
Yeah, yeah. So that's the reason I'm showing. So yeah, this is all those are great thoughts, and it turned out to be a paraganglioma. And I was wondering why this is one of the favored locations. Why should we think of paraganglioma when we talk about this? So I just found these two lines, which I definitely feel are useful. So junction of IVC and the left renal vein and Zucker canal are more common locations for paraganglioma, but even anterior to the right IVC is the locations where paragangliomas of the sympathetic chains are located. That's also where we should suspect paraganglioma, as in this case.
Mm.
Awesome. That's a huge one. Was it, do you know if it was malignant?
Mm, I don't know right now, but I can check that.
What's UB on your PowerPoint?
Urinary bladder.
Oh, okay.
That's just a Yashantism.
Yeah, I mean, at times it's better you just write short and just get things done. MC is most common.
You didn't know MC either.
Wait, what's MC?
Most common.
Oh,
These are for his own notes.